Hello everyone, this is Nimra and I will be speaking about this clinical vignette. Before I begin on the case, I would like to talk about immune checkpoint inhibitors. Even though most of us may not be necessarily the ones prescribing them within the oncology office, because of the increasing use on multiple different types of cancer patients, it is necessary to know the different side effects that patients may present to it. Our objective in this case clinical vignette is to describe a case of suspected cytokine release syndrome in a patient enrolled on a phase 1 trial which included a PD-L1 inhibitor, avelumab, and an oral DNA PK inhibitor. The initial thought process was that this is septic shock or actually likely toxic shock syndrome. So beginning with the case, this was a young 38-year-old woman who had an ependymomal tumor. She was on a phase 1 trial, which included the PD-L1 inhibitor and the oral DNA PK inhibitor, and she had presented with a fever and rash. The onset of the symptoms began actually a few hours after receiving the avelumab infusion. On exam, she had a temperature of 39.2, heart rate was 148, she was hypotensive, 87 on 45, and she needed to come to the ICU for what was suspected septic shock. And she was on 98% on ambient air. Examination was significant for an alert and conversant woman with macular erythema, which involved the face, chest, and upper extremities and thighs. She also had a long-term indwelling PICC line and a peritoneal catheter. There were areas of desquamation on the chest and also on the upper extremities, which made us feel more inclined that this could be toxic shock syndrome. She was treated with multiple antimicrobials and including clindamycin. However, her clinical status remained unchanged after 12 hours. It was then decided to start methylprednisone for a possible adverse reaction to the avelumab, and a few hours after the methylprednisone, it was also decided to start tocilizumab for cytokine release syndrome. Her condition improved dramatically within the next 24 hours, and she was transferred out of the ICU by day 3 and actually discharged home on day 7. On a follow-up appointment, her immunotherapy, it was decided to stop her immunotherapy and change her to an alkylating agent. We have table 1 over here, which shows the results of the pertinent lab work. And this figure over here can show you the macular rash on her face. The rash was also present on the arms and chest. I think this case was important because we're describing a case of cytokine release syndrome, and it can frequently present something similar to septic shock. And this can be encountered by people who are not necessarily oncologists. Hence, why it's important to disseminate this information to other practicing clinicians. Cytokine release syndrome is like a systemic inflammatory disease characterized by a release of multiple cytokines, and IL-6 is known to play a key role. And doing a literature search, we found that although cytokine release syndrome has been described by other checkpoint inhibitors, it has not specifically been described with avelumab, and we noticed that rash was only described in 2 of the case reports. We found that tocilizumab was used in 2 of the case reports and mycophenolate was used in 2 other cases. Steroids were used in all cases, and there was recovery in almost all the cases. Because of this, I think we can conclude that due to the increasing use of checkpoint inhibitors, more clinicians need to be aware that they can trigger cytokine release syndrome. Thank you.